me welcome my co-chairman, Professor Magdi Haggag, Professor Ayman Muhyiddin, Professor Hisham Sharafuddin, and Professor Francesco. We may ask for the first presenter, Professor Ahmed Ismail. He will talk about guidelines of management of venous compression syndromes.
Assalamu alaikum. Thank you, Dr. Mustafa, for the presentation. And to start, I would like to thank the organizing committee for the invitation. And my talk today will be about guidelines of management of venous compression syndromes. Actually, my presentation will be based on the International Union of Angiology consensus document on vascular compression syndromes, which is published in August 2023. So this is the last update. Vascular compression syndromes may be arterial or venous or combined. We will talk very quickly like train stations. We will start with popliteal entrapment syndrome, which is entrapment of the popliteal neurovascular bundle at the popliteal fossa. 6 types described. The first 4 is arterial only. The type 5 and 6 is arterial and venous. Heidelberg classification simplified the classes into 3 types. Type 1 is a problem in the course of popliteal artery. Type 2, problem in the muscular insertion. Type 3, both of them. The pathology is usually thrombosis, embolization, and aneurysm formation. The diagnosis of popliteal entrapment syndrome is usually by high clinical suspicion. The patient type is usually athletic, young age, bilateral in 30%. The main symptoms are leg and foot exertional pain, which is alleviated by rest, and the diagnosis based on physical examination, provocative maneuvers, ABPI may be decreased, MRI and the duplex ultrasound are the mainstay in diagnosis. The decision making on popliteal entrapment syndrome to operate or not to operate. Symptomatic popliteal entrapment syndrome typically requires surgical intervention. Type 1 to type 5 do surgical release, but type 6, which is functional popliteal entrapment syndrome, usually observation. Involvement of the vein warrants decompression. Anomalies of the medial head of gastrocnemius muscle caused entrapment in 60% of patients. Anatomical course of venous anomalies were found in 7% only. Using stents or any endovascular procedure is very limited in such case due to extrinsic high force of compression. Ultrasound-guided Botox injection can be helpful and described, but further studies warrant to determine the efficacy and durability. Shifting to thoracic outlet syndrome, which can be neurogenic thoracic outlet syndrome in 95% of cases, venous thoracic outlet syndrome, or arterial thoracic outlet syndrome. The etiology is variable. Sporting individuals, musicians, manual workers, which perform repetitive movements, raising the hands above the shoulder level, can cause neurogenic thoracic outlet syndrome. Half of patients of arterial thoracic outlet syndrome found to have cervical ribs. Third, found to have tissue anomalies. Hypertrophy of subclavius or scalenus anterior muscle or impingement at the costochondral junction by costoclavicular ligament or callus formation after fractured clavicle, all these can cause entrapment of the subclavian vein. Why? Because the subclavian vein is adherent to the undersurface of the clavicle. Diagnosis can be based on chest X-ray, duplex ultrasound, provocative maneuvers, CT and MRA. All these can lead to the diagnosis. What are the management guidelines for venous thoracic outlet syndrome? In younger age group, swollen limb interfering with activities should be offered intervention with thrombolysis followed by surgery. Patients with late presentation beyond the optimal period for thrombolysis, beyond 14 days, should be treated initially with anticoagulation and reviewed at 3 months for evidence of dissolution of clot. Then at this time, surgery can be offered for release of the impingement. Catheter-directed thrombolysis in acute presentation at young age group is safe when the clot lies. Treatment with low molecular weight heparin or DOAC should be continued until surgery is performed. The goal of surgery is to achieve complete decompression of subclavian vein and avoid subsequent complications to happen again. Several known approaches for decompression of thoracic outlet syndrome: transaxillary, supraclavicular, infraclavicular, combined approaches, but balloon angioplasty and stenting is not advised in this region due to high incidence of rethrombus. So in thoracic outlet syndrome, no stents is advised according to the guidelines of International Union of Angiology 2023. Follow-up intervals: 1 month after surgery by duplex imaging. The patient reassessed after 6 months, 1 year, and patient with arterial thoracic outlet syndrome can go with single antiplatelet therapy. But with venous thoracic outlet syndrome, after decompression, can go on oral anticoagulation for 3 months. Going next to nutcracker syndrome, which is compression of left renal vein between the superior mesenteric artery and the abdominal aorta. This is anterior nutcracker, but the posterior nutcracker between the aorta and the vertebral body. It is relatively frequent incidental finding without symptoms, which is called nutcracker phenomena. If with symptoms, it is nutcracker syndrome. Symptoms may be microscopic hematuria, proteinuria, varicocele in males, and pelvic congestion in females, and left flank pain. All this variety of symptoms and may be asymptomatic. The imaging criteria quickly are renal duplex ultrasound, which can measure the peak velocity ratio and the diameter ratio between the narrow and the congested segment. CT imaging, which can elicit the aortomesenteric angle, which is normally around from 35 degrees to 65 degrees. If below 16 degrees, or like all literature, below 35, it is considered the narrow aortomesenteric angle. CT venography is considered to measure the pressure gradient between the dilated and the non-dilated segment. The management of nutcracker syndrome basically is the first therapeutic approach should be conservative treatment. In pediatric population, the pathology is not resolved spontaneously without surgical treatment. In adult patient, conservative approach consists of weight gain and performing exercise to the back muscles with evidence of use of venotonic drugs and antithrombotic medications. If conservative treatment failed, we have to consider, but the endovascular first approach is not the gold standard for nutcracker syndrome. After the first period of enthusiasm related to the technique of stent implantation and ovarian vein embolization, serious complications started to appear. Why no endovascular stenting is recommended in nutcracker syndrome? This area has great mobility with high flow, where implant can have a risk of migration with serious consequences ranging up to 7% of cases. Left renal vein is conical in shape, especially if compressed at the aortomesenteric angle. It is very narrow here, and a peak sign with bigger volume of the vein near the hilum of the kidney. So there is no chance to do stenting because of this conical shaped left renal vein, because there is no conical shaped stent. So endovascular treatment in these cases currently restricted only to cases with very hostile abdomen and to rescue after surgical complications. Several surgical approaches were described for relief of left renal vein compression, like transposition of left renal vein to IVC, transposition of gonadal vein to IVC or pelvic veins, transposition of distal left gonadal vein to left common iliac vein, bypass from left renal vein to IVC, renal autotransplantation, external stenting or radical nephrectomy can be performed. Follow-up of nutcracker syndrome after surgical reconstruction should go for 6 months at least on anticoagulation. Unresolved issues and goals for future research: there is no dedicated stents for treatment of nutcracker syndrome. Having in mind that stents should be used in cases like failed surgery, posterior nutcracker syndrome, or very hostile abdomen. Taking in mind complexity of open repair, patients should be transferred to referral center. Going to May-Turner syndrome, which is extrinsic compression of iliac vein by the arterial system against bone structure. The most common vein to be compressed is the left common iliac vein, compressed by right common iliac artery. But it is not only the vein which can be compressed. Also, the right common iliac vein can be compressed against right common iliac artery, left common iliac artery. Right internal iliac artery also can compress the right common iliac vein, right external iliac artery, or even the aortic bifurcation. Left external iliac vein can be compressed by left external iliac artery. Right external iliac vein can be compressed by right external iliac artery. And IVC itself can be compressed by right common iliac artery. Patients with May-Turner syndrome can present with extreme heterogeneity of symptoms like asymptomatic venous claudication, edema, DVT. All patients with left-sided chronic venous disorder should be investigated for becoming May-Turner syndrome. If vein compression is evident, we have to exclude any other cause of compression, like tumors, internal iliac aneurysm, bladder distension, spondylolisthesis or lumbar discopathy or lymphadenopathy. Clinical stages and diagnostic evaluation of May-Turner syndrome, and the workup should be done by duplex, which is difficult to diagnose because of deep location of internal iliac vein and surrounding inflammatory reaction which is present. So we can depend on MRV or CT venography, which can show the collaterals with pancake appearance of the area of arterial compression. IVUS is a very valuable tool in such case, which can recognize the method of choice of a diagnosis of May-Turner syndrome and help to identify the compressed area and provide information about the healthy area before the compression and healthy area after the compression for the landing zone for stenting. Okay. Treatment of asymptomatic patients with May-Turner syndrome, even with high-grade stenosis or occlusion, is not supported by any evidence. From C3 to C6 C classification, we can do endovascular intervention by stenting. For the sake of time, I will skip some slides. Conservative measures for mild symptoms. Crucial points for choice of stenting procedure. The stent should be high radial force with good flexibility, and IVUS guidance is very crucial, and there is no difference statistically between dedicated venous stent and non-dedicated venous stent in current literature. Post-stenting, the patient should go for anticoagulation if
Conclude, Ahmed.
3 minutes more than 13 minutes now? Okay, go to conclusion. One word I want to say, at last, I finished May-Turner syndrome. I want to highlight venous compression syndromes of the neck. 2 points of internal jugular vein compression, either by very long styloid process against the arch of first cervical spine may compress the internal jugular vein, and omohyoid muscle hypertrophy, which can also compress the internal jugular vein. These cases are our cases, and we can do release of internal jugular vein to avoid the complications. Going to conclusion, Mr. Chairman. Vascular compression syndromes are rare and little known entities that represent a very important subset of vascular pathology. Diagnosis is challenging due to rarity and non-specific clinical presentation and lack of knowledge. Duplex ultrasound is the first line examination for diagnosis. IVUS allows direct evaluation of endoluminal content in certain conditions. Digital subtraction angiography has been the mainstay of imaging-based diagnosis because Vascular compression syndromes are caused by external compression of vessels. Endoluminal treatment alone is rarely adequate, and surgical decompression is likely to be required for optimal and durable clinical benefit. And thank you for your patience.
Okay, thank you. We go next speaker, Dr. Ihab Saad, and which will speak about thrombolysis, if we still have a role in acute DVT intervention. And please be an effort to be on time.
Okay. Assalamu alaikum. I hope everyone can take coffee before last presentation for this session. I would like to thank Professor Mutwalli and Professor Walid Khleiba for this nice arrangement for elegant conference. I will not take a long time. My presentation today about the castor thrombolysis still have a role in the acute DVT intervention. Post-thrombotic syndrome is a clinical condition defined by the signs and symptoms resulting from the acute DVT. This is usually a consequence of the ambulatory venous hypertension resulting from the valve reflux and or luminal obstruction. Studies have shown that patients with post-thrombotic syndrome have a significant reduction in their quality of life, and the severity of the patient's acute DVT is a predictor of the post-thrombotic morbidity, especially when it involves the iliofemoral segment. Patients with iliofemoral DVT have an occlusion of their single venous outflow channels from the leg, often resulting in severe post-thrombotic morbidity when treated with anticoagulation alone. In a prospective observational study of anticoagulation for the acute DVT, iliofemoral DVT was found to be the most powerful predictor for the severe post-thrombotic syndrome. When spontaneous lysis occur as a sequel of the DVT, it is defined as the clot resolution, which occur within 90 days, and in this situation, the valve function was frequently preserved. And this is intuitive that the elimination of the acute venous thrombus restore the luminal patency and increase the likelihood that the valve function will be preserved. That's why there is a trend for the rationale for early thrombus removal. And there is a reasonable body evidence supporting that the strategy of the early thrombus removal, especially in patients with the iliofemoral DVT. When this strategy of thrombus removal is successful, definitely the venous patency is restored and the valve function can be preserved and the quality of life improved and the risk of recurrence is reduced. Different methods for early thrombus removal. One of them, which is the famous, is the castor dialytic therapy, have rapidly replacing the systemic thrombolysis as the preferred method of the early thrombus removal in patients with extensive deep vein thrombosis. And the evidence suggests that the castor-directed lytic therapy may be beneficial, especially in patients with the iliofemoral DVT. And the case-controlled study demonstrating significantly improved the quality of life in case of the iliofemoral DVT in patients treated with the castor-directed versus anticoagulation alone. And this is the classic casters for the used for the castor dialytic thrombolytic therapy. I think the details all of us is well known, and the most common casters used with the technique was the pulsed spray technique. Most common through the popliteal vein, sometimes through the short saphenous, sometimes through the femoral itself if it is only localized to the iliofemoral segment. The most commonly used lytic agent are the plasminogen activator. Urokinase doesn't work or doesn't available in Egypt, or common tissue plasminogen activator, and the lytic drug is infused together with the usually unfractionated heparin or low molecular weight heparin, both weight adjust the giving in the solution of the saline. The thrombus free through the popliteal, usually the most used accessible vein, and this puncture under ultrasound guidance in the prone position. And this is some photo of the early formal DVT and how is the complete lysis, but the most important not to leave any part of the patency is sluggish circulation or stenosed, because this is almost always responsible for the recurrence of this situation and doesn't improve the outcome. Other methods, the more residual thrombus at the end of the catheter-directed therapy, the worse of the quality of life. And there was also correlation with the objective measures of the post-thrombotic syndrome. The greater the degree of lysis, the fewer the symptoms of the post-thrombotic syndrome. That's why almost always we must not doing the lytic therapy, but looking for the complete patency of the iliac segment and must be treated by balloon and stenting to achieve the excellent result. Is there other methods? Yes, the not only pharmacological but pharmacomechanical technique also in combination with the thrombolysis have been developed to more rapidly clear the venous system. The pharmacomechanical technique have been shown to improve the outcome compared with the catheter dialytic therapy with this drip technique alone. And this shortens the treatment time and reduce the dose of the agent and reduce the length of the ICU hospital stay. Ultrasound accelerated thrombolysis, also this is reported initial experience with the ultrasound accelerated thrombolysis in many patients, and comparing the result, one of the excellent technique to improve the result of the complete clearance of the iliac segment. Angiojet, although it is, we used it in Mansoura, but is not adequately good result like we expected from the angiojet in our locality, but one, although it's so expensive, but is also most of the study now replacing it by other methods, especially the mechanical. And for the summary of the randomized trial evaluating this early thrombus removal, there have been 4 randomized controlled trials examining the effectiveness of early thrombus removal strategy. This is the Toledo study and the Cavent study and the Attract study and the Cava study, all of which suffer from a combination of methodological and technical flaw. But the meta-analysis of all of this study, it is evident that although early thrombus removal technique are more effective than the anticoagulation alone in preventing and particularly moderate to severe post-thrombotic syndrome, there is no trials offering direct comparison between the stenting and no stenting after early thrombus removal. Nor any of them comparative trial comparing to allow for decision between the catheter dialytic therapy alone or in conjunction with the pharmacomechanical or pure mechanical study. In conclusion, and my conclusion is the recommendation. Recommendation is the guideline. The recommendation 34 in selected patients with symptomatic iliofemoral deep vein thrombosis, early thrombus removal strategy should be considered. And recommendation 35 for patients with deep vein thrombosis limited to the femoral or popliteal or calf, early thrombus removal is not recommended. For patients with iliofemoral deep vein thrombosis who undergo early thrombus removal, it is recommended that the choice of the therapy is based on the judgment of the treating physician. In the NICE study in 2020 also giving a reasonable recommendation considering the catheter dialytic therapy, especially in young aged patients with the recent iliofemoral DVT, especially if there is extensive threat to the limb like phlegmasia like in this situation. Thank you very much.
Thank you, Professor Hab. Now we shift to Professor Amr Abdelrahim. We'll talk about deep vein stenting step by step.
Assalamu alaikum. First, I want to thank the organizing committee for holding this tremendous meeting here for the third time in Ras Al-Bar. Venous stenting step by step. It's very important topic. We have to consider very important points in this topic. First, patient with deep venous disease fall in two categories. Those who have known deep vein thrombosis and subjected to the post-thrombotic change, or those with compressive syndromes, that to say Neville or non-thrombotic iliac vein lesion. The indication for interventions according to the guideline that those with clinically relevant venous outflow obstruction with CEP score more than 3, with venous severity scoring system pain score more than 2, and presence of more than 50% stenosis in the deep venous system. Or those patients with deep vein thrombus acute iliofemoral DVT, and then after removal of the thrombus we found a stenosis more than 50% which is need this lesion to be managed by stenting. Or those with pelvic venous problems, pelvic venous congestion, and has got the deep vein stenosis, and that asymptomatic patient shouldn't be considered for venous stenting. According to Angiology, this was in the link 2020, the classification of chronic venous obstruction, he classified the chronic venous obstruction into 5 categories. Those type 1 is the Neville lesion, that is compressive or compression syndrome. 2, the iliofemoral thrombus is not extending to the common femoral vein. 3, extending to the common femoral vein but above the bifurcation. 4, A and B according to extension to the profunda or the femoral vein. And type 5, both the profunda and the femoral vein are included. This is my case, a patient with his early 30s who has got a previous deep vein thrombosis and has got a disabling edema and heaviness, venous claudication in this left lower limb, and he seek for treating his deep vein obstruction. So to start with, there is very important aspect should be addressed. First, from the entry side, the patient should be prone. The patient may be prone or may be supine. Okay, I prefer the supine position because you have many axes to the post-femoral vein and maybe to the jugular vein as well. You have to have many axes to help your patient. And our axis when the patient is in the supine position will be the femoral vein. It's duplex guidance. We address the femoral vein in the upper half of in the thigh. The vein is present in the adductor canal, although the artery is just above it. But when the patient flex his hip joint with external rotation, you can have some obliquity that you can address under duplex guidance. You can address the vein without puncturing the artery. And then, after you gain access, you have to we proceed with to assess our inflow. This is the next step. We have to assess our the inflow, because the inflow is very important. No inflow, no patient. Here, this patient, according to Angiology classification, the patient has got a common femoral vein intact. I mean, the thrombus is not extending to the common femoral vein. Oh, sorry. Can femoral vein in the thigh. After we have, these is the collaterals, multiple collaterals, because the obstruction in the iliac segment, I mean the common, the left common iliac vein, the left thin iliac vein. we use the a step wire, guide wire, to go through the lesion. We can use the supporting cast as well. Don't worry about faulty extensions of the wire. Faulty extension of the wire or occurrence of multiple perforations, this is nothing to make any problem within the venous system. And you can use intralesional venography, and this gives a chance to the tract, how to go through the tract. Very important, you see here the wire is going from a nice pathway from the left to the right side in the common iliac vein and the IVC. It's very, very important to take different views. Because if the wire makes it to the left side, I mean to the ascending lumbar, for example, and this is the faulty pathway. But even here, although it seems to be in the common iliac vein, it may be not in the common iliac vein, but it may be in the veins around the spinal canal. So we have to take different views so that to be sure that the wire is anterior to the vertebral column, not behind it. So it's very, very important to get different views. By the way, it's here, it's a normal pathway, but take care of this faulty passage. After we gain access to the IVC, the next step, we have to do balloon dilatation. And the balloon dilatation should be with the same diameter of the intending stent. Here in the common iliac and the external iliac, the stent around from 12 to 16 millimeter diameter. And we can use the other common femoral vein, the normal side, to get to know the confluence, so that not to jail over the contralateral side. And then after balloon dilatation, pre-dilatation to get to the diameter you want to put your stent within, and then we start to put our stent, which is here. It was a wall stent, which is a closed cell stent with very high radial force, and after concomitant angiography from the other side, we could precisely detect the site of deployment of the stent without jailing. As you see here, I put a catheter in the right side, and after venography, I start deployment of the stent without jailing over the other side. Take care, the stent should go beyond the spinous process and near the edge of the vertebra to be sure you are in the proper side. Very important here. It's very important to show this. Take care. Here, after deployment of the proximal stent, and then I put the other stent, and I want to be sure that I should put the stent at the proper inflow. As I mentioned, no inflow, no patient. So we have to put the stent in the proper site, in the inflow. So after I put my stent, I mean the proximal stent, and to securing the inflow, and I put the distal stent before it to secure the landing zone, the distal landing zone. I found here that there is a gap between the two stents. So it's permissible to put a third stent in between the both stents, I mean, and let the overlap within the pelvis. Don't let the overlap behind the ligament, because this is a sign of failure. Okay, and you can, by the way, you can go below the ligament, although you have to try to avoid it, but you can go below the ligament during venous stenting. So after I found this gap here, I put another stent to fulfill or to cover this gap between the proximal and the distal stent. Okay. After that, I do the venography at the end, and we have a nice pathway. The stent is properly deployed, and the flow is go freely to the IVC, and by double venography from the right and the left side, we have this nice venography at the end. So this is important point to do venous stenting. Very, very important. This is my steps in the venous stenting. We have to conclude that we have to put a dedicated venous stents. Using dedicated venous stent, we cannot use our in the venous circulation. We need to put a stent with a very high radial force and at the same time very flexible. And this is not the condition of the arterial system. Different dedicated venous stents present in the market, no major difference between them. And if we follow the rules we have mentioned during stenting, we could have a proper outcome. Thank you.
Now, Dr. Abdulaziz Abdul Hafiz, hybrid approach as adjunct to iliofemoral venous stenting in extensive chronic iliofemoral venous obstruction, a case presentation.
Bismillah ar-Rahman ar-Rahim. First of all, I'd like to thank Professor Mitwali Rajab and Professor Ayman Fakhri, also Professor Khalid Atiyah and Professor Walid Khariba for this nice conference. I will talk about hybrid approach as the adjunct to iliofemoral venous stenting in chronic iliofemoral venous obstruction. Chronic iliofemoral venous obstruction is a clinical pathological condition of the systemic veins that can be due to several etiology and that may play a significant role in chronic venous insufficiency or venous hypertension. Etiology can be primary non-thrombotic or secondary post-thrombotic. Iliofemoral DVT treated by conservative treatment.
عزيز تسمح لي عشان الوقت بس نجمب لليور كيس.
حاضر يا باشا. طيب انا بس هقول بس الحته ديت الناتشرال هيستوري بتاع الاليوفيمال دي في تي تريتد باي كونزرف تريتمنت هيمودايناميك امبيرمنت associated with post thrombotic syndrome occurred in about 80% venous claudication in 40%, reduced quality of life in 60%, limited ambulation in 15%, venous reflux in about 70%, venous ulceration in about 30%, recurrent DVT are common. We did a lot of cases in Al-Azhar hospital in Cairo, combined endovascular and open reconstruction hybrid technique are performed in chronic iliofemoral venous obstruction associated with affected common femoral vein or when creation of arteriovenous fistula is required to improve inflow following intervention. Technique of hybrid approach including endovascular part and open part. First we did preoperative venography to assess the lesion, then endovascular part in form of passage of the wire, and then exposure and control branches of common femoral vein and profunda, longitudinal venotomy, dissection and endovenectomy, then closure by batch. Then we do venoplasty and stenting. After that we do arteriovenous fistula. This is example number one, a male patient 39 years old with history of right DVT 9 years ago, presented by BTS and venous ulceration C6. We can see a total occlusion here in preoperative venography. We can see a total occlusion of common iliac, external iliac vein and external iliac vein and severe attenuation in common femoral vein with a lot of collateralization. We did endovascular part in form of passage of the wire, venoplasty by balloon 16 in diameter, and stenting by stent 18 in diameter in common iliac artery and 20 in diameter in external iliac artery. Then we did the operative part in form of endovenectomy and arteriovenous creation by a synthetic graft. This is the ulceration pre and post after 1 month with clinical improvement. The second example, a male patient, 35 years old, with history of left DVT 4 years ago, presented by BTS and venous ulceration C6. The preoperative venography showing common iliac and external iliac total occlusion, also with the severe attenuation of common femoral vein and a lot of collateralization. We did the endovascular approach by venoplasty and stenting, followed by operative part with endovenectomy of the common femoral vein and arteriovenous creation by using natural graft. This is the pre and post venous ulcer after 1 month follow-up. Factor affecting patency curve of venous recanalization, adequate inflow in the stent is essential for future patency. So with extensive iliofemoral occlusion, the stent can be extended caudally to the inguinal ligament into common femoral vein or the profunda. For the best possible result to be achieved, the following pre-operative and post-operative management must be urgently considered: sufficient therapeutic anticoagulation and antiplatelet, early mobilization, compression therapy, and systemic follow-up. The primary patency rate about 80%, secondary patency rate more than 84%. Procedure success depends on the quality of inflow and outflow. And thank you.
Now, Dr. Sameh Mustafa, IVC filter retrieval, feasibility and difficulties, situations. Dr. Sameh.
Thank you, Mr. Chairman, my dear professors and colleagues. Good evening. Today I'm going to speak about our experience in Alexandria University concerning retrieval of their IVC filter. First to go, when to put a filter. Several guidelines are concerned with the indication of an IVC filter, including the American Heart Association, British Committee for Standards of Methodology, and European Society of Cardiology. However, they are all consistent about the three indications, which are contraindication of anticoagulation or need to stop it, complications of anticoagulation, and recurrent pulmonary embolism with therapeutic anticoagulation. The third one is always permanent. However, these two indications might be temporary. So in these conditions, we consider retrievable filter. Why to remove a filter? We remove a filter due to long-term complications, including filter tilt and embedding inside the wall, IVC thrombosis, filter migration, filter migration, and filter penetration. In Alexandria University, we conducted a prospective study, included 20 patients for 18 months. They all had these demographic data and the temporary indications of IVC filter deployment. Two types of filters are removed, the conical one on the left side and the hexagonal one on the right side, which is removed through the same site of insertion. The dwelling time mean was 60 days, and we followed the IFU for filter removal in all our cases. 75% of the procedure are done under local anesthesia and sedation. The rest is done under general anesthesia due to either irritability or temporary arrhythmia. We had three techniques in our procedure. The first one is a standard snare technique. Here, this snare technique, through the retrieval sheath, we encircle the hook part of the filter, engagement. more engagement, folding of the filter inside the retrieval sheath, and after that removal of the filter and completion angiogram. Another example, through the femoral access to remove a hexagonal filter, encircling of the hook, engagement, folding of the filter inside the sheath, and removal. This is a simple way. Sometimes we didn't have the snare in our institution, so we made a wire loop using a diagnostic wire, which is a little bit stiff in this shape. After that, we encircle the top part of the filter here through a transjugular approach, engagement of the hook part, and folding inside the retrieval sheath with its removal. However, in some cases, 4 cases, 20%, we need to use both the snare and the wire. Why? Because we had adherent of the filter inside the wall. The hook part was very adherent to the IVC wall, as we see here. So we use the wire loop in this way in trial to dissect away and push the filter, realigning it towards the retrieval sheath. And after that, we got the filter hook by a regular snare, and then pushing the sheath forward. And as we see here, we can see both the filter, the retrieval snare, and the wire loop inside the same sheath. A success of this procedure was done in 90% 18 patients. However, we failed to retrieve the filter in 2 patients due to extreme adherence to the wall. We had complications in the form of mild self-limited extravasation, 2 cases in 1 case, 2 cases of pleural hematoma, and 3 cases of temporary arrhythmia. 2 interesting cases we met during this study. This case, we tried the ultrasound-guided transjugular approach to catch the filter from the top. However, the wire didn't pass through the IVC with extreme resistance. It went either to the right side inside the right hepatic vein or to the left side inside the left hepatic vein, but didn't pass through the IVC. We thought that the IVC is thrombosed. So I had another femoral access and had this venogram with free flow of the dye inside the IVC up to the chest. So I tried to put a wire from below, thinking to snare it from above and complete the mission from the above. But I had intraoperatively the imagination of having a valve or a web of the IVC. So I tried to put a curved catheter like this and withdraw the wire to reshape the catheter, push it up to the neck sheath, and after that I tried to pass the wire from the above. It passed easily. After that, the case is converted to a regular snare technique. After a while, MRI was done for this patient for another reason and revealed a congenital web of the IVC just below the level of the hepatic veins. Another difficult case of a conical shaped filter. We tried to remove it using this snare. However, the filter didn't move a bit inside the IVC. So we had this venogram. We found that the side wall strata were highly stuck to the wall. We used this double wire loop technique in trial to embrace the filter from its right and left side, gently rocking the filter to have some movement. After we had some movement, we withdrawn 1 wire, keeping the other holding or just abutting the filter, and introduced a snare, catch the hook part of the filter, just securing it inside the retrieval sheath. After that, we withdraw the other wire and withdraw the filter inside, and with complete removal, completion angio, thanks to God, was normal. This technique, I told myself, it's very, very dangerous. I'll never do it again. To conclude, the message is IVC filter retrieval is feasible and non-time consuming. Whenever you have temporary indications for the IVC filter, consider retrievable filter and the removal. Always stuck to the IVU, always stick to the IFU of the manufacturer, especially the dwelling time of the filter inside the IVC. Otherwise, you will have complete sticking to the wall, which is very difficult and might be fatal. Even while sticking to the IFU, sometimes you have some adherence, so you try gentle maneuvers. But even with this, within the IFU dwelling period, you might have severe adherence to the wall with stenting of the IVC wall like this. And in such a case, please withdraw your retrieval sheath, disengage your snare, and leave your filter alone, as or because permanent filter is an option. Thank you.
Thank you, Dr. Sameh.
Thank you.
And now we open the floor for discussion. One question for each speaker, please. Regarding the first presenter, Professor Ahmed Ismail, any question for him?